Hello, I'm Cynthia Chin in the Department of Neuroradiology at UCSF, and I want to share some of the strategies that we have used to reduce patient radiation exposure during our CT-guided spine interventions. Our first slide shows some of the common spine procedures that we perform: epidural injections, facet blocks, nerve blocks, radiofrequency ablation of the facet joints, and biopsies in patients with suspected infection or tumor. Many of these injections are done to treat spinal pain related to spinal stenosis, disc herniations, facet arthropathy, and nerve and canal compromise from spondylosis. In our next slide, you can see where we perform our procedures. This is at the Outpatient Precision Spine and Peripheral Nerve Center. And here we are in the picture inside our CT scanner during a procedure. You can see the in-room monitor allows us to observe and follow our trajectory as we advance the needle to the intended target in the patient. Our next slide shows the epidural injection. The diagram shows the thecal sac in green with yellow nerve roots within it. And around the thecal sac in black within our red circle is the epidural space. The axial CT scan on your right through T12L1 shows an actual epidural injection. Within the yellow circle, you can see the thin, high-density contrast outlining the thecal sac after injection of medication to treat back pain. The next slide shows an example of a nerve block. The diagram shows within the red circle the yellow nerve root and within the foraminal zone. On the axial CT scan through L5S1, we can see 3 arrows on the patient's left pointing to that small soft tissue structure, which is the nerve root. On the patient's right, a needle has been placed to the dorsal margin of the nerve root, and high-density contrast outlines the nerve root nicely after injection to treat the patient's right lower extremity radiculopathy. The next slide shows an example of a facet block in this patient who could not walk more than a block due to back pain from spinal stenosis related to his facet arthropathy. And you can see the yellow arrows on the image on your right pointing to the bony overgrowth and spurring that results in some narrowing of the spinal canal. The axial CT images on your right show the needles placed and advanced to the facet articular space for injection of medication, which in this patient resulted in significant pain relief that allowed him to walk his usual mile. And so the small spaces that need to be accessed, such as the facet joint articular space, as well as the epidural space, as well as small structures such as the nerve root, are ideally suited for CT guidance, and we perform our injections and interventions under CT guidance. And this modality has been shown to provide accurate and precise placement of needles in these types of injections to treat patients. And along with the privilege of using CT guidance, we know that the challenge to us is to adopt protocols that allow decrease in radiation exposure for the patients without sacrificing outcome or image quality, as well as to reduce the variability that is inherent when different physicians perform these types of injections. And our next slide shows the 3 strategies that we have found to be very helpful in reducing patient dose as well as provider or physician variability. And that is 1, to know beforehand where your needles will be placed so that the anatomic targeted survey for localization can be minimized. Second is to lower the tube X-ray current. And the third is, instead of using helical acquisitions, to use axial acquisitions that then will prevent the overraging or the overlapping that can result in unnecessary exposure for the patient. Applying these 3 simple strategies, we have found that we can reduce substantially the radiation to the patients as well as the variability in patient radiation for the procedures performed by different radiologists. To assess the impact of these measures on radiation reduction, as you can see in this next slide, we collected information for the first 50 patients that followed implementation of these changes and compared it to 50 patients who had procedures done before implementation of these three simple strategies. And what we found then was that a reduction in image contrast was not significant enough to affect the technical success or the immediate pain relief for these patients. And in fact, the mean DLP decreased substantially from 1,500 to less than 200 milligrams per centimeter. The CT technique that we used is seen in this next slide. On our GE Lightspeed 64 slice CT scanner, we used a rotation time of 0.8 seconds, a tube potential of 120 kV, slice thickness of 2.5 millimeters, a collimation of 40 centimeters, a pitch of 1.375, a detector coverage of 40 millimeters, and the noise index was not adjusted. So our next slide illustrates how we divided each procedure into three phases. The first phase is the survey or the scout or localizer images, and these allow one to plan the trajectory for the needle to the intended target, and that's called the survey component or phase. The second phase are the repeated images used during placement of the needle along the trajectory towards the target, and we call this phase the guide phase. The third component is the contrast phase. When the needle has reached its intended target, injection of contrast confirms adequate and precise needle placement. And so images were obtained in this particular patient who had the same procedure, a nerve block and a facet block, in 2009 before implementation of the strategies, and in 2010 after implementation of the three strategies. And we can see that the images acquired in 2009 compared to 2010 are of high quality for both years, and that the intended targets for the needles were reached successfully, and the patient outcome also was not different between the 2 years. But what you can see that is different is that the MA that was used for all phases of the procedure was significantly decreased in 2010, with the survey view in 2009 of greater than 500 MA decreased to less than 200 for the survey view in 2010. In fact, it was at 150 MA. For the guide view, MA was decreased in 2009 from 84 to 30 MA. And for the contrast view, from 199 MA to 50 MA. And this resulted in a total examination reduction in dose by 91%, without change in technical success and without change in patient outcome. This patient experienced the same degree of significant pain relief in 2010 as she did in 2009. The next slide shows in these tables that between 2009 and 2010, there were significant reductions in the DLP for the total procedures, as well as the survey, guide, and contrast phases for all patients. When we divided into cervical and lumbar interventions only, the same significant dose reduction was identified. In fact, the mean effective dose for the cervical only and lumbar only guided injections was reduced in 2010 from 9.7 to 1.1 millisieverts for the cervical only, and 17.5 to 3.3 millisieverts for the lumbar only injections. Our next slide shows an example in a patient who had right trapezius and upper forearm pain. And we can see sagittal and axial MR-T2 sequences shows arrows pointing to a relatively open foramen and normal nerve root on the left, and circles around the C5-6 right foraminal space, which is significantly and severely compromised by uncovertebral and facet arthropathy. The next slide shows the AP and lateral scout on the CT view that just targets the level of C5-6, not the entire cervical spine, and the sagittal and coronal reformats that were obtained from these targeted views. The yellow arrow points to the equivalent on CT of the severe foraminal narrowing that we had seen originally on the MR images. These are the 3 axial localizer or scout or survey views that were obtained, and you can see that this was at a substantially reduced dose of MA of 30. We often will obtain just 3 slices, less than a centimeter of tissue exposed, and at this very low MA you can still see that the image quality is high. In fact, the yellow arrow is pointing to our planned trajectory to the severely narrowed foramen, and that we can avoid, as you can see in image 1, the circle around the vertebral artery. The next slide shows 3 images obtained during the guide and contrast phase, and this is at an even lower MA in the same patient. So during the guide phases, with advancement of the needle over multiple passes, we can do this at a lower MA than obtained during the survey view, and you can see that the needle reaches its target, and a jet contrast shows the precise and accurate placement of the needle in this patient undergoing a C5-6 nerve root block for his trapezius and upper forearm pain. And in this particular patient, the dose, you can see, is quite low, less than 30 DLP. And this is an equivalent to an effective dose as low as 0.17 millisievert. This is a dose that is equivalent or lower than what has been reported for fluoroscopy-guided procedures. The next slide shows the relative contributions from the different phases of the spine injections. So we can see that this changed substantially between 2009 and 2010. There were significant reductions in DLP during the guide phase of the examination in 2010 that lowered its contribution to total procedures from 57 to 20%. In 2010, almost 75% of the patient's dose came from the initial survey or localizer or scout CT images that are obtained for identifying anatomy that's relevant to the patient's spinal pain and prescribing the course of the needle insertion. The next slide shows the comparison of total examination doses for different CT-guided injections, and we can see that between 2009 and 2010, the total dose decreased significantly for all 3 specific types of CT-guided spinal injections with statistical significance. Selective nerve root blocks were consistently higher in total dose, likely due to the inherent soft tissue contrast needed to identify these very small structures, especially when there is significant foraminal compromise. The next slide shows that were observed for CT-guided spinal injections by individual supervising neuroradiology attendings. And we can see that there's significant reduction in radiation dose for each of the attending supervising neuroradiologists. And we can see that this study highlighted the fact that there can be substantial radiologist-dependent variability in patient dose. And by using the proposed strategies and protocols as we outlined, that the differences in DLP between the highest and lowest supervising neuroradiologists can be substantially decreased. And in fact, these were reduced 95% from 1776 milligrams per centimeter in 2009 to 94 milligrams per centimeter in 2010. And this reduced variability in the radiologist-dependent procedural radiation came without any sort of monitoring or any sort of mandates. It just happened naturally using the 3 strategies that we outlined. And therefore, what resulted was a more consistent protocol resulting in a more uniform exposure for the patient that was independent of any particular supervising neuroradiology attending or institution. The question often comes up, well, what if there are multiple sites that need to be accessed? How best to achieve intervention in patients with multiple sites? And this next slide shows 3 sites in one patient that needed to be injected. 3-4 facet and nerve, the 4-5 facet and nerve, and the 5S1 facet and nerve. And so we see the 3 localizing survey or scout views that were obtained. And we perform each of these at the same time. They are acquired during the localizing phase in the same sweep. And as we can see here, the guide phases are also imaged at the same time. 3 slices per level, less than a centimeter of tissue exposed for each of the site. And so these were performed at an MA of 10. So you can see the 2 needles approaching the facet and the nerve for L3-4, 2 needles approaching the facet and the nerve at the L4-5 level at an MA of 10 during the guide phase, and 2 needles approaching the L5S1 level at an MA of 10. And you can see that the exposure is quite minimal, with the DLP measuring only 106.73 for this particular multi-level, multi-needle, multi-injection procedure. And we can see in this next slide the table graph showing that for lumbar-only procedures that the dose is significantly decreased when we use this particular approach, regardless of the number of levels done or the number of sites injected. DLP approximately reduced 80% between 2009 and 2010, and similar reductions were identified also for the cervical-only procedures when normalized, like here, for the number of sites or levels treated. Now, if you don't perform types of injections as we've shown here, nerve blocks and facet blocks, you can also apply this to biopsies, which is done in all different subspecialties in radiology. And here we have a patient with an MRI that shows pathologic compression and involvement of the cervical and upper thoracic spine with metastatic disease from his known primary bladder cancer. These MR images in the sagittal and axial plane with and without gadolinium show that there is abnormal enhancement and abnormal extension into the epidural space at the level of the metastatic involvement, and that it involves not just the bony structure but also the soft tissue. The outside imaging from this patient under CT with routine MA of greater than 600 shows the involvement of the bony architecture here at the facet level on your left. The DLP for this outside image was greater than 400. With the knowledge from these outside images, we could target our specific level during our scout phase, and we lowered the MA to 250. And yet the image quality is still high, and we were able to see the pathologic involvement at the level of the facet. During the guide phase, the MA was decreased even further to 50 and still allows high quality imaging of the target and allows for accurate and precise needle placement into the pathologic area. And the biopsy came back positive for metastatic disease in this patient, and the DLP compared to greater than 400 for just the diagnostic cervical spine study that was done was at 240. And so in summary, the radiation exposure from CT-guided spine injections decreased substantially without affecting outcome in our patients. And we did this with 3 simple strategies: reducing tube current, using axial acquisition, and eliminating non-essential imaging guidance. And these measures also decreased the variability in the radiation doses between different practicing physicians.